So welcome back to session 2, which will take us up to our lunch break. Don't forget to use the chat box to comment and use the Q&A box if you want to ask questions of the speakers. But I'm now going to introduce the chair of session 2, Aimee Robson, who is Deputy Director of Personalised Care at NHS England and Improvement, and has been very heavily involved with the work of the MSK Lived Experience group that you've heard people talking about this morning. So over to you, Aimee.
Thank you, Sue, and thank you to ARMA for the invite to chair today and the ask to facilitate this wonderful session where we have 4 speakers across sort of 2 chunks to the outline of this next session. So what we'll do today is we'll have 3 sessions from Alex Trompeter, from John Skinner, from Rebecca Steinfeld, and then we'll have a quick break, and then we'll have a session from Natalie Beswetherick after that. So just to remind everyone of the context of this piece, this section is around some grouped topics around doing things differently with some really useful, interesting, thought-provoking examples for us all. And just to remind those of you on Twitter, #MSKTogether, which I'll pop into the chat box, and Q&As and chats in the chat box as we've been doing throughout the morning session. So first session is going to be about the NHS Change Challenge, locking in the beneficial changes post-COVID. And we've heard a little bit about that this morning from Andy Bennett, but also from Christina. So it'll be great to get a bit more of a deep dive into it and some great questions. Alex works at St. George's University Hospital in London and holds the position of Honorary Reader in Orthopaedic Surgery. Over to you, Alex.
Thank you. It's lovely to be here. Really appreciate the opportunity to share with you the experience we've had from NHS E&I on the Change Challenge. So I'll just share my screen, 1 second. Get that going. Good. So the title of this talk, or really what I'm going to spend the next few minutes telling you about, is the NHS Change Challenge. So I'm Alex Trompeter. I'm an orthopaedic surgeon. I have a special interest in trauma and fracture surgery. I work at St. George's in London. The Change Challenge team is a huge group of people, and this is absolutely everybody's work. It's certainly not mine or mine alone. I'm just the lucky person who's come to tell you about it today and give you some of the sort of overview of what it was and our experience. So the first thing is, what is the Change Challenge? We have a short video. Hopefully it will play.
Alex, I don't think we have the sound.
Hold on. Apologies.
And you may not have ticked the box that says
we may have to do without the sound. So I shall explain what crowdsourcing is then. Apologies about that. The emphasis in crowdsourcing is to move away from the traditional small group of expert people giving their opinion on how to evolve or change a service, or how to deliver a service, or really how to think about anything. And that's typically how we do things in medicine and healthcare, and have done for many years. Experts come together, they give their opinion, they form a consensus, and then that's fed out into the wider community with an array of solutions. And what the crowdsourcing method does is it's a much shorter process. Normally the expert opinions require several meetings, lots of paperwork, lots of sort of rounds of discussion and so on. And then over several months or even longer, output can be delivered. Crowdsourcing focuses the mind, and it brings in all of the stakeholders in a process to provide their opinion, their feedback on a variety of areas. So in this instance, the stakeholders for crowdsourcing in the Change Challenge were all of the MSK communities. So that was orthopedics, rheumatology, pain management, spinal services, rehabilitation, the patient, and so on. And what we asked for essentially in the period that this was done was, through the COVID crisis, what had worked well in your unit, what had worked well in your service, and how are we going to capture that change going forward? Very clearly, a huge amount of change occurred during COVID because of the way we had to deliver our services in extreme times. And naturally, by a process of natural selection, the poorer ideas of change probably got left by the wayside, and many units came up with solutions, some very similar, some very different, some only minor tweaks, some very radical, that led to a lot of change happening in a very short period of time across a broad spectrum of the MSK community. And our aim, the mandate from NHS INE, was to look at how can we capture that. So crowdsourcing was asking for everybody to get involved, provide their evidence and examples of what they'd been doing. And then by a proper process of analysis, we were able to then put that back out to the community to give people an idea of the good things that were going on around the country. So I'll go on a little bit more detail about how it actually worked. So it involved a huge amount of people. NHS E&I had an array of people involved from all aspects, from project management, from horizons, from communications, and so on. We had patients with lived experience, people with lived experience giving their input, which was absolutely essential. This was all supported by the professional bodies, including the British Orthopaedic Association, ARMA, Chartered Society of Physios, and so on. Crowdicity itself, which is the platform we used, provided the IT and the tech through the NHS Fellows as well, NHS England. And then we had a series of clinical champions. Those were specialists in each of the different domains that we looked for ideas. So I was the responsible champion for urgent and unplanned care, but we also had champions from physio, from spine, from elective orthopedics, from rehabilitation, from pain management, and so on. You may have seen these couple of slides, and I won't dwell on them, but Andy put these together, and they're really important in understanding the nature of what we were trying to do. MSK covers an array of topics, as you've heard, but also throughout the sort of domains of our community, primary care, right through to tertiary and specialist care. So we were trying to capture things across the board, not just hospital care, not just sort of treatment specific, but looking at rehab, looking at community pathways, and so on. And all of these are intrinsically linked, and it's really important, and that's why this had to cover the scope of MSK. It couldn't just be orthopedics, it couldn't just be rheumatology, it had to be all of MSK conditions together, and it received really good support from across the board and all the responsible bodies. When we divided things up, actually when we started, there were fewer themes. We ended up with quite a few more. As we went through the initial phases, we realized there were quite a lot of areas that we had to focus on. So there was very clearly a need to include primary and community care and the sort of triage of referrals into the hospital stream or to MSK services. Rheumatology itself, pain management, spine, elective orthopedics, and urgent care were the sort of clear clinical areas that we had to focus on. Rehab as well. You know, we spend more time with our patients in rehab than we do with the actual sort of definitive treatment of the condition, if you like, or the direct treatment of a condition. We looked at the way partnerships were formed and how groups were coming together to work across these different sort of domains within MSK. And then actually there were some important areas that we thought about, which were some of the changes about what was stopped in services. So what do we actually not need to do that we've always done that we seem to manage okay without during the process? The timeline was fairly short. It was only about 4 months really from initial meetings through to the first round of output, which is pretty rapid given the scope of the project. There was a lot of initial discussion looking at how we're going to set it up, what we wanted from each domain, what the domains were going to be. The challenge actually opened to people sort of submitting their ideas in the middle of May and was closed a month later. So there was a 30-day window for people to submit. So a very short period of time to sort of glean the views of the community. And then there was about a 6-week period where we went through and analysed each of the submissions one by one, and there were quite a few, before then disseminating and sort of re-informing the community about what's happened with their ideas. And then we have some ongoing work now about the bigger areas of dissemination, and then going back to NHS E&I with some of the key ideas that might need even more support at a national level. So ultimately, the output aim of this project was to firstly dip our toe in the water with the idea of crowdsourcing. This has not been done in the healthcare community like this before in the UK. It's really quite novel. It was done, the first sort of way it was done was around trying to get the idea about COVID testing and getting people's ideas and systems at a scientific level to decide the best way forward. But in terms of asking our healthcare community how they were providing services and what was going on, this was the first time. We had a long list of ideas that we had to then look through, and really the aim there was to give the community feedback on each idea. So every single idea got graded and sort of fed back. And then some of the key ideas, the highest scoring ideas, were championed and got a bit more in-depth analysis. And it doesn't mean that the lower scoring ideas weren't good. I'll explain a bit more about how we defined a high score and a low score. And then ultimately, we're in the final output phase for phase 1 here of this project, which is disseminating this information. So presenting the output at meetings like we're doing now. And we're in the process of writing 3 or 4 publications around this piece of work to hopefully go into press early in the next year. So the process was quite robust from a scientific point of view. There was submission in a very tight window. There was a thematic analysis and a filtration process with a scoring and ranking tool set up through the fellows unit. And then ultimately the process of bidding these ideas back to the representative bodies. In a little bit more detail, you can see how we looked at this. So each idea was given a thematic analysis, i.e. which area of MSK did it fall into? Was it to do with patient communication? Was it to do with IT and tech? Was it to do with rehabilitation or something? So each one got usually several areas and domains that it fell into. The impact and the feasibility were the key areas of how we scored the ideas. So impact was, what difference is this going to make to patient outcome, ideally, and patient experience, or financial dividend, or improving population health. And then feasibility was a separate idea, or separate scoring system, which really looked at primarily whether it aligned with the plans for MSK, as Andy's slides previously had highlighted, and also then whether the idea is sustainable and scalable. And it's really important that they were separated, because something could have a phenomenal impact but be totally unsustainable and unscalable, cost prohibitive, or just, we don't have the infrastructure in the NHS to allow that to go ahead. So it may score high in one and low in the other. The magic ones were the ones which scored high in both. And then ultimately we were able to produce a case for change. The way we looked at the ideas in terms of horizons, these weren't part of the scoring, but really kind of just allowed us to group the ideas into their novelty, if you like. Horizon 1 is kind of something we're doing already, but maybe had tweaked slightly. So pretty much could be enacted straight away. Horizon 2s were a little bit of a building on what we did already, maybe a slight change in the way we deliver services, moving things forward into the 21st century, and need a little bit more support in getting them going, but are very manageable. Horizon 3 were really kind of new ideas, new things that we're not doing, but are probably still, in the scope of stuff we kind of know about and dream of. And then Horizon 4 were really the transformative, completely visionary ideas that were just revolutionary.
Alex, I'll give you a 1-minute warning.
Thank you. This is just an overview of the challenges and what we saw in terms of the different domains and how they were provided. And then ultimately, we went through each one, each challenge. And for example, in emergency care, We had 29 ideas promoted. There were 116 conversations and 60 people had interacted. So each of the different domains had loads of different interactions. I can go through in a little bit more detail for those that are interested in the specifics of what the interactions were, but everything has now been fed back into the Crowd Challenge, Change Challenge web portal. So you're welcome to go and visit there and see what has been made of your idea that you promoted. So it's been a really exciting project to be involved in, and thank you for the opportunity for me to update you on where we've come to now, and I'll happily take any questions later on. Thank you.
Excellent. Thank you so much, Alex. And what a wonderful program that is. Thank you for providing a very concise message on a very complex topic. Thank you so much. We'll do question and answers at the end, if that's all right for all the panelists in this section. So thank you, Alex. And thank you very much for that outline. Next, over to John Skinner. John, you're going to be speaking with us about restarting orthopedic services. And John, I won't be able to do an adequate introduction to your breadth of portfolio, so I will let you do that yourself. Over to you.
Thank you very much, and good morning, everybody. I just get this up. Can you see my screen?
No. Not yet. There you go, John, yes. It's up.
Right, thank you. Sorry about that. So good morning, everyone. John Skinner. I'm an orthopaedic surgeon at Stanmore in North London, and I'm the president-elect of the British Orthopaedic Association. So I'd like to talk a little bit about restarting elective orthopaedic surgery. I talk to you as an orthopaedic surgeon, and obviously orthopaedic surgery is one part of musculoskeletal care, and the vast majority does not require surgeons, but when it does, we know that surgery can make a big difference. So the issues what we're talking about really is the 11th of March, the World Health Organization declared a global pandemic with SARS-CoV-2 virus. And they said that COVID will remain endemic with probable peaks for a significant time. And I think that's where we are now. We've had the first horrific shockdown meeting a new disease that none of us knew anything about, when all elective surgery shut down, to an area where we're now getting going again, but we're still living with the virus and it's still up and down, peaking, and prevalence is different in different parts of the country. And elective surgery, I think we all know, but it is important. Elective does not mean optional surgery. These patients, by the time they get to us, really need an operation. And we know that this year there have been 212,000 less operations performed on musculoskeletal patients than last year. That's a 73% reduction. And that has caused significant problems for us and for everybody. So if we've got a problem, what are we going to look at? We've got to look at the outcomes. Is it worth persisting with surgery? Well, it certainly is. Decision making, the only thing you can elect about elective surgery is when you do it. And for some patients with morbidities and problems, there may be a reason for delaying it. Some people in extreme pain need to go ahead. We know that musculoskeletal care is a team event. None of us can do it on our own, but we need primary care. We need to expand the way of seeing patients. We know referrals are down, that during this, patients stopped presenting to primary care. And we know that the referrals at one stage were down to 20% compared to last year. and they're still not back to normal. So there is a backlog out there, and we're going to need first point of contact practitioners, we're going to need primary care, we're going to need therapists, we're going to need different people from different specialties to start seeing patients and managing the first wave of care. We know there are always codependencies, that I cannot operate on somebody without a team. I need high quality nursing, I need therapists, I need mental health support sometimes, I certainly need primary care, rheumatology, and we all work together. There are costs, and the country doesn't have a lot of money, but it is expensive, and it's not a saving not to do the treatment that's needed at the time when it's needed. And teaching and training, we've lost, I said we were 212,000 operations down. In surgery, that's 212,000 training opportunities we've lost. And all of us in every single branch of musculoskeletal care have lost training, and the trainees are suffering. So what about joint replacements? Well, it is big business, 112,000 knee replacements a year, preponderance of females, average age 69, knees predominantly for osteoarthritis. Hip replacement, similar numbers. So with primaries and revisions, we're getting on to 220, almost 250,000 operations a year, again, predominantly female. And so it's a big need, and we've got to keep doing it. Safe surgical restart, what do we need? Well, we've got to prioritize. If you've got a limited resource, you can't do it to everyone. So you've got to work out who needs it most. And that's been difficult, but we can all work together to help prioritize and spot the deteriorating patient and get them jumped up the list. We have to test patients beforehand. We've got to have informed consent. We think it is better if you test staff, screen patients for symptoms and tests, and it makes things better. And we've got to deliver green COVID-like pathways. We've got to have PPE, and we've got to have a sensible discharge strategy. If we're discharging into care homes, social care, that has implications. If we're discharging back to the community, we've got to make sure there's adequate support. And the issue, I don't know if everyone's aware of this, but we all have to tell patients now, if you're going to have an operation, if you get COVID, during the recovery, it does seem to have significant respiratory complications and even the potential for death. And this came from the initial COVID surge pathways. We've now got an awful lot more experience of planned surgery during a pandemic, and we think the risks are not as great as they were, but we cannot afford to take any chances. And so these are complex considerations. We've got to make sure patients can comply with them, have the mental capacity, and social factors are all taken into care. So we've got to separate urgent and planned care, and that's not just now, that applies all the time. And before the COVID pandemic, what COVID has done is amplified inadequacies in the system. It wasn't working that well before, we had big waiting lists. And so now we've got to work ways to deliver elective surgery year round. We need COVID light or green pathways, and those that need surgery, and there will be those who we don't know the COVID status on or positive, also have a care pathway. I've talked about symptoms and temperature checking. That happens in most, I think all NHS institutions, has to be done daily, and you have to report contacts, and we have to be honest and diligent. We swab all our staff and swab all patients prior to surgery, and I think that is the way to go. And as new testing comes in, we'll work out frequencies. We feared, I mean, obviously aerosol generating pathways, intubation in someone with COVID does generate aerosols, and it's important that we protect and keep the workforce safe and keep patients safe. But orthopaedic surgery, although COVID can be in the blood, it is not generated into aerosols in levels which seem to cause respiratory infection. So that's, as long as you're not operating on paranasal sinuses or airway, bones involved in the airway, then the level of protection changes a little bit and allows you to behave more normally. But we must have the right levels of PPE. And again, it depends on the local prevalence, whether you've got pathways, whether you can isolate, whether you know the status of staff and patients. And healthcare workers will always be at the front line and one of the highest risk groups for picking up COVID. So joint replacement, fantastic operation. Very few get reoperations. The risks for problems are increasing age, so extreme age, very low or high BMI, low socioeconomic groups and poverty and the issues associated with that, and mental health issues. People with poor general health, people admitted to hospitals in the same year, have poorer outcomes. as do those with smoking, alcohol and drug consumption. So we have to all work hard to make sure that outcome doesn't relate to income. If you have joint replacement at the age of 70, the lifetime risk of revision is incredibly low. It's between 4 and 7%, which makes it very effective healthcare. How do we stratify patients? Well, 4 categories: 1A within 24 hours, 1B within 72 hours. These are fractures, these are injuries, these are obviously myocardial infarctions, but in the MSK world, acute trauma and hip fractures have to be done because we know delay costs lives. It makes outcome worse. Category 2 needs to be done within 4 weeks, category 3 within 3 months, and category 4 over 3 months. And a lot of joint replacement patients are category 3 or category 4. And the figures, unfortunately, are significant. That in January, there were 436 patients waiting for orthopaedic operations more than 52 weeks. There are now 31,000. We're about to start reporting not 52-week waits, but 104-week waits. So there is a massive need to get surgery going. 270,000 patients waiting more than 18 weeks. And so if you could wait more than 3 months on day 1 when you went on a surgical waiting list, it's pretty certain you can't wait 3 months a year later. And we've got to look at the ways we keep those patients in condition, informed, communicated with. What can we do with therapy? We've got to keep patients moving and talking, because isolation, pain cause depression, misery, and have massive effects on every aspect of health. And we know that NICE say you should refer patients for joint surgery before prolonged established functional limitation and severe pain. We've now got them referred, but we've got them on waiting lists and not being operated on. We need to work out how we manage those to keep them safe and effective, because in an elderly population, you have to keep people moving. We all know that if you keep people moving, they control their weight better, their heart function is better, their bone strength is better, coordination is better, they fall less. And it's good for diabetes, it controls sugars. And so that's what we've got to aim to do. So what do we look at? Pain is the #1 reason for surgery. We can look at length of stay, we talk about activities of daily living. And we know that if patients are working, if you have a joint replacement, the majority will get back to work. If we let them decondition and have a long period off work, then less patients get back to work, and that's understandable. So there is an imperative to act for these patients. That a significant improved quality of life and leisure activities. These are people, if you get people active, and they can be carers, they can help in the community, they can keep people out of social care and keep out of social care themselves. And if you're out of pain, then patients had more sex and better sex. Everything in life is easier if you're not in chronic pain. And it's important that all of us are contributing towards that. Patients always put pain first and have high expectations from hip replacements, that 80% no pain, 16, so 96, 97% are expecting almost normal function after hip replacement. And we can get there. This is a group of patients up to 20 years, Oxford score on the left, it's out of 48. Once you get them up, the recovery is very high and it is maintained for a long time. This is really good value healthcare. And NICE tells us that too. For hip replacement, the cost of quality adjusted life years, NICE says 20 to 30,000 pounds is value for money, and joint replacement is right up there. If we look along the left, so surgery for brain tumor at the bottom, it's expensive, but obviously needs to be considered. Hemodialysis, no one's going to consider not doing kidney dialysis or CABG, coronary artery bypass surgery. Cataract first surgery. Hip and knee replacements actually are right up there at the top in terms of quality of life. And we know it makes a difference. These are patients, the graph shows, again, the Oxford score on the left, 0 to 48. And you can see that if we let the Oxford score go less, to drop down, average score for joint replacement is around 19 to 21. If we let it go low, everyone gets better, but there is a ceiling effect. Keeping patients away from surgery makes a difference. They get better, but not as good as they could have done. And that's something we're all very aware of. I think everyone involved in musculoskeletal care knows that as pain increases, Patients just defunction, they withdraw, they stop going out, they stop going up and down stairs, they make a pile of stairs at during the day and only go up at night taking things when they need it. If you're not sleeping and joint pain does that, then the days are very long. Patients change their life, they don't go out. If they're driving, if they can't park close by, they don't go. They stop walking, and everything has knock-on effects for all aspects. And patients are fearful of losing independence and becoming a burden. But what is left? If you don't do the treatment that's needed, then we can do a limited number of things with therapies, with osteopathy, with chiropractic. We can help symptoms, but sometimes the only treatment for pain is pain relief. And these would never have been considered in the past for joint pain. But if you've got patients you can't operate on, there will be a place for them, but we have to all keep an eye on them. If patients are on opioids, we need to all ask, how long have they been on them for? Do they still need them? Because although they have a role, escalating doses of opioids for arthritis really doesn't help. And patients on opioids for a long time is not beneficial. We know there's an awful lot of significant effects. Hip replacement was called the operation of the century in the Lancet. And we can get, it is cost effective. It is always cost effective to do joint replacements. And NHSI have said that the cost is between £9 and £10 a week for a hip replacement, which is really good value. An NHS prescription is £9.15. This is a patient that I was lucky enough to perform a hip replacement on, and this is a week after his operation. And he sent me this video, I'm sure not to show me the digestive capabilities of his dog, but just to show that within a week, he's walking like this. He's now at a stage where skilled therapy will get him walking normally, will protect his back. But before that, he couldn't get in a car. Smoking, again, it does affect results, but it's difficult. Surgery works in smokers because smokers get out of bed quickly. But what do you do for addictive personalities? We haven't got much else, and it's not a good idea to give them the strongest painkillers, I would have thought.
John, 1 minute warning from me.
Thank you. Our challenge for elective surgery is to demonstrate it needs priority. We all know that elective surgery can be deprioritized. Anything else can take priority. That we know it's clinically effective. We know it's cost effective. We know it's better than some of the alternatives, and it can affect an awful lot of people. We know delay matters, and it harms patients, and we all have to work harder for when we delay and to stop patients coming to harm. And we all have to optimize patients until surgery can happen. But we've got to keep the whole pathway functioning, and that's people's coming in when a big backlog's built up, people being seen first point of contact, people being managed from the beginning, people being managed until they can have an operation, and then managed from surgery and rehabilitation afterwards. So to finish, it is highly effective relieving pain and restoring quality of life. It is one of the most effective of all operations. It's got a very low level of revision surgery and high satisfaction. And unnecessary delays deny people who would benefit from surgery. They increase the onus on all of us to look after them. And I'm afraid patients do come to harm. It leads to poor results in those who do need surgery. Thank you very much.
Excellent. Thank you so much, John, for a wonderful evidence-based, thought-provoking narrative there in context of this piece, which is around doing things differently and offering some really useful challenges in the evidence for us. Thank you so much. Excellent. Next, over to our third speaker and then for this session, and then we'll take a 5-minute break. Next, we are off to Rebecca Steinfeld, who's the head of policy at National Voices. And Rebecca, I'll let you introduce yourself and get going. I'll let you take control of the screen.
Okay, thanks so much, Amy. And thank you to Sue and the team at ARMA for inviting me today. Let me just try and load some slides. Can you see that? Yeah, okay. So I'm here today to talk to you about doing things differently in digital and about improving the digital healthcare experience. I'm head of policy at an organisation called National Voices. And for those of you who don't know who we are a coalition of around 166 health and social care charities across England. Some of those big household names that you will have heard of, like Age UK, Arthritis Action, Diabetes UK, ARMA, of course. Some of those are smaller charities supporting those with rarer conditions, disabilities and impairments. And our mission really is to further humanise and democratise health and care. We work on things like increasing person-centred care, trying to combat health inequalities, system design, service delivery, and really trying to bridge between the VCSE sector on the one hand and then the statutory sector on the other. And today, what I wanted to talk to you about, 4 things essentially: what we think is working well in digital healthcare, what needs improvement, the urgency and importance of tackling digital exclusion, and how we must remember to personalise care everywhere, whether that's online or face-to-face. So the reason I'm talking to you about digital healthcare in particular is because COVID-19, as I'm sure many of you will know, either as people using services or as people providing services, has really accelerated the digital healthcare revolution. Pre-COVID, around 5% of GP appointments were online. Since COVID, that's now 85%. And 85% of GPs want to continue remote consultations. So this seems like a digital healthcare revolution that is here to stay. So we have done some research with Healthwatch England and with an organisation called Traverse about people's experiences of using digital healthcare. And we did that very rapidly in July through some interviews and workshops. And the feedback that we got back from that presented quite a mixed picture. On the one hand, people seemed to think that there was a lot to be celebrated about the digital healthcare experience and reported lots of positives, things like feeling comfortable, confident, listened to, informed. On the other hand, people said that there were lots of negatives about their digital healthcare experience, that they felt apprehensive, frustrated, disappointed. You can see those in the speech bubbles there. So just to sort of talk a little bit more about what those positives are, because I think before we talk about what needs improvement and what's really not working for people, I think it's very important that we actually acknowledge what is good about this sudden switch to digital. Now, lots of people said that they felt it was more convenient to have a remote appointment because it meant that they didn't have to take time out to travel somewhere, sit in a waiting room. They could just stay at home and get on with what they were getting on with. And interestingly, for particular groups, it can improve accessibility. So, for example, for people who are experiencing physical disabilities, it avoids travel, which can be very difficult and complicated, or the emotional strain of having to actually go to a physical healthcare setting. Things like having closed captioning or the ability to record sessions to play back later was also something that people who had other disabilities said was very useful. From a health point of view, it also minimises the exposure and the risk of exposure to COVID and other illnesses that could be transmitted in a germ-filled waiting room. It gave clinicians an insight into people's living environments, which would help them build a better picture of people's lives outside of a clinical room. It created a level playing field for patients to meet with providers. And the break in routine, clinicians said, was a chance to rethink communication with patients. So there's definitely a lot to be celebrated and acknowledged as positive here about digital healthcare. And here's one example for you. So somebody said to us, they'd had a physiotherapy appointment by telephone, and she said, I didn't know what to expect. The physio created space to ask about how I was doing. I felt heard and was able to ask questions. It was refreshing. A normal physio session would be in a crowded room. 5-minute instructions, you practice the movement, they pop back after seeing other people and ask you how you're getting on. It's rushed. I see about 15 to 20 health professionals a year, and this is the most person-centered session I have had. So that's a really glowing response to the digital healthcare experience. But then, of course, there are negatives. And things that people said in our Doctor Will Zoom You Now project included things like a lack of information and support being given in advance of the remote consultation, a lack of choice about whether or not the consultation would be on the telephone or it would be by video. And if it was by video, what specific app was being used and what was involved in accessing that. People told us that they felt some conditions were not served by remote care. For example, foot examinations for people suffering from diabetes is one of the things that's come up. There were also safeguarding concerns about not being able to see someone outside of their living environment, and about problems that could pose in terms of their ability to talk openly about what they were experiencing. And then, of course, there were barriers to access and use, which are summarized in the term digital exclusion. So you can see up there, there's a quote: "My consultation was via the telephone. In both of my consultations, it would have been better if a teleconferencing platform was used like Zoom or MS Teams." So what do people want from digital healthcare? Well, these are some of the things that they told us that they wanted. One was boundaries, being given a reasonable time window in particular for their remote consultation, so that they would know when to expect it and be able to be in a place where they could talk confidentially, calmly, they could prepare questions in advance, things like that. Preparation to get the best from an appointment. So being told exactly the length of their appointment, how much time they'd have to talk about things, and what platform was being used, so they'd have an opportunity to download in advance, things like that. They also wanted to have a clear message that going virtual shouldn't mean a compromise on the quality of the interaction, and that quality communication was maintained through the digital healthcare platform. They felt that information sharing would be very useful, and that the most should be made out of the platform as was possible. So things like the ability to easily share links and images, even patient records, and recording sessions, so that people could then play back later and think things through in their own time. And most crucially, giving people choice about whether their consultation would be on the telephone or by video or face-to-face, depending on their particular needs. So that's really about how to improve the quality of the digital healthcare experience for people who are able to access and able to use these kinds of platforms and services. But I think it's really important in talking about this subject that we acknowledge that a significant proportion of the population is digitally excluded. Now, the reasons for that digital exclusion are numerous and complex. Income certainly plays a part. For example, not being able to afford to have a device that enables you to download whatever app it is that your healthcare provider is asking you to engage with, or people who are not able to afford contracts that include lots of data. So again, can't afford to get online for healthcare. Language also plays a role, as does literacy in general, and then digital literacy in particular. And so does confidence. People are not having the confidence to be able to use digital healthcare. It's also important, I think, that we recognise that this exclusion really isn't equally distributed. So some people are much less likely to be online. That includes older people, people with disabilities or on low incomes, and then specific communities. Migrants, for example, travellers, people experiencing homelessness are all less likely to be online. And these are all groups who are much more likely to face health inequalities in general, and therefore have poor health experiences and poor health outcomes. There's also the issue here, I think, of what I've called a double inequality. And by that, what I mean is that if you can't get online to access healthcare, it's highly likely that you also can't get online to access a whole range of services that many of us take for granted and that underpin our health. So food, employment, education, social support, all of those things. So I think here what we have to bear in mind is that there's an interaction effect whereby digital exclusion further exacerbates health inequalities, both in driving up poor health and then in creating a barrier to accessing healthcare. So you have a speech bubble just in the top right there, an example. My mum was called by her GP reception to say they would have a remote consultation the next day. She has dementia and no digital life, so this was impossible. There was no follow-up. So I think that we all need to be thinking about how to tackle digital exclusion. in whatever we're doing. I think there's a role for VCSEs like ourselves in terms of building confidence and helping people to upskill. Some examples I've heard recently, organised by an organisation called The Big Local. They've been distributing refurbished devices where they really sort of strip them back and pare them down, so they literally have the one thing that someone has said that they would find so useful to improve their health. And that might be something like WhatsApp or Skype, just so that their sense of isolation can be eased. And I think modeling that best practice to upstream is really, really helpful. I think there's a role for health services here. So ensuring that alongside digital healthcare provision, there are also things like callback services and free phone numbers, and prioritizing face-to-face for people who are digitally excluded. And then old-fashioned methods like posting accessible information in the mail. And you can see some more suggestions in a British Medical Journal article, Online and Left Behind. I think there's also a role here, arguably, for government in that internet should be recognised, internet access as a basic need. There is already wide recognition now that digital exclusion is a social determinant of health. So I think there is a corresponding onus at a much higher level for there to be recognition and provision of internet access as a basic need. So I think that's all part of the picture of how we both improve the quality of the digital healthcare experience and then address those people who are falling through the gaps and who are not able to benefit from it. But I think in all of this, what we have to bear in mind is the sort of, going back to first principles, that care has to be personalised everywhere, whether that is online or offline, whether you're speaking to someone on a video call or you're speaking to them face to face. And so one of the things that we've done as an organisation, when COVID started, we set up an online platform called Our COVID Voices. And we asked people who were living with long-term physical and mental ill health to share with us what they were experiencing during the lockdown. And from that, we distilled what they said into 8 core, what we call I statements, which are essentially 8 first-person statements that express people's health and care needs right now. And we co-produced these statements with the people who had originally submitted their stories and their experiences to make sure that we accurately reflected what they told us. And I think these really capture what is so important right now in health and care. So let me just tell you what they are. The first thing that people said to us was that they need to know that they are listened to and that what they say is acted on. They also said, I make decisions that are respected and I have rights that are protected. They said they're given information that is relevant to me in a way that I understand. So this is really all about shared decision making and giving people the information that they need to be able to make a decision that is right for them and having that decision respected. Something else that came out very strongly was around risk. And they said that I'm supported to understand risks and uncertainties in my life. And that very much reflects, I think, the moment that people were talking to us in lockdown. But I think it's still true today that a lot of people feel that they haven't yet been sufficiently supported to understand risks and uncertainties in their lives, which enable them to make a decision about how they want to proceed. And it was interesting actually to see in John Skinner's presentation that table where you took a systematic approach to saying when the surgery was recommended and people's level of risk, and then helping them to therefore make a decision supported by you about what would be right in terms of when they had their hip replacement or knee replacement. I think that's really, really great example of something that could be used to help people understand risks and uncertainties. People also said that they want to know how to talk to the personal team in charge of my care when I need to. And that's something actually that we really beefed up in a subsequent report that we've done about people's experience of waiting for care, that I was also thinking about during the last presentation in terms of knowing how much longer people now are going to have to wait given the backlog. That it's so important in terms of supporting them and preventing them from deteriorating further, that they know who to talk to, if they're in a crisis, if their condition significantly deteriorates, and just to give them the support that they need while they're waiting. The 6th I statement was, I know what to expect and that I'm safe when I have treatment and care. And I think that's still highly relevant for people. whilst COVID continues to circulate before a vaccine is rolled out widely, people really need to know what's been done to keep them safe when they come for care. And then they need to see those things are actually in place. So if they get a letter that says we've done X, Y, and Z, and then they turn up and actually it's total chaos or it's not the system that they expect, that really undermines their trust and then their ability to go and get the care that they need at that moment. Another thing people told us was, I'm supported and kept informed while I wait for treatment and care. And again, we beefed that up and suggested exactly the kind of information that people should be given while they're waiting. And we've been working with NHS England with the elective care task force to help them develop a minimum information standard to support people while they wait. And finally, perhaps the strongest thing people said was that they are not forgotten. The message that we heard loud and clear on our COVID Voices and in the workshops that we did with people was that they just felt that they had been forgotten and abandoned. And they said that it was very important that people recognized that and changed how they were treating and supporting people so they didn't feel that way anymore. So what now? I think really what I wanted to get across here and what I hope you'll take forward from this is that it's really important, I think, to recognize the positives and the potential of digital healthcare, and that doing things differently that way can really improve people's experiences of health services and also then their quality of life. At the same time, I think we do need to recognize where there are problems, where quality could be improved. And it's crucial that we continue to offer people choice, that we don't do just digital by default, but that we really think carefully about what kinds of conversations need to be had face-to-face and who needs to have conversations face-to-face. And I think in line with that, we really need to urgently tackle digital exclusion head on so that we don't wind up further exacerbating the sorts of health inequalities that COVID has made so stark. We really need, I think, to think very carefully about the sorts of actions we need to take at all levels to make sure the digital healthcare revolution actually narrows these health inequalities and doesn't make them worse. And finally, I think we need to recommit to personalising care in digital as elsewhere. And that's it from me. Thank you so much.
Thank you very much, Rebecca. And what a wonderful session that's been, hearing some really interesting work that's happened through the COVID pandemic from the different perspectives of different organizations, teams, and projects. Thank you to our panelists, and a virtual round of applause, as I'm sure you can hear in the chat box and the questions that are popping up. There's a few questions that have popped up through the question and answer, and we have between now and 12 o'clock to go through some of those. And what I'll suggest is that I'll take the highest voted questions. There's probably one for each of you, and then we'll try to make through the rest of them as best we can. The first one's for Alex. Alex, it relates to the beneficial changes piece. It says a huge amount of work has gone into this, so well done to all involved. Moving forward, are there efforts to make this type of process more organic, ongoing, rather than retrospective? Thank you, Susan Julians, for that question. And it says, can you use patient questionnaires or similar to shape policy more quickly?
Yeah, absolutely. This is an ongoing process, and the whole point is that it will continue to evolve. We actually had patient groups involved, and Christina's been involved, so that's an integral part of it. And in fact, the process doesn't work if we don't include the patient. So everything is patient-centric to a degree. I mean, there are things that we've included as well about the health and well-being of staff and how we deliver our services for our benefit as well. And we mustn't forget that, you know, the staff are humans as well and have an incredibly important role to play in delivering services. And if people aren't happy in the way they deliver services, then that needs to be considered. But absolutely, working with Andy still, who's been instrumental in this, we're looking at what the next chapter is for this project, but it's ongoing and it's prospective at all times.
Great, thank you, Alex, and thank you, Susan, for the great question that kind of brings to light the what next, the so what factor. So thank you very much. Next one to you, Rebecca, if that's okay. The next most voted one was around great presentation, positives around digital session. Let me just read this, some really useful text from Sally. I think it's more of a, what a poor and hold on, felt she's commenting on what the narrative of the non-rushed compared with a physical session. I guess really what's at the heart of that question from Sally for me, Rebecca, is around what can we do to really make that challenge that was posed in that really helpful description from that patient, saying it didn't feel rushed compared with now. What can we do now to make that part of the new norm from your perspective?
So one thing I would say is we have top tips. I think I linked to them in the presentation, both for healthcare professionals and for patients, about how to get the most out of your digital healthcare experience. So there's lots of information there that people could use. I think specifically in relation to not making it rushed, I think setting a specific time for an appointment with a time window, and making sure that someone is prepared in advance so that they're not scrabbling around at the last minute to sort of download the app, which then isn't compatible with their phone or whatever it is. I think that sort of preparedness is really, really important. Yeah.
Excellent. Thank you, Rebecca. And thank you, Sally, for that question. Apologies if I garbled it. And if I didn't get the sentiment of it right, please pop another question through. John, there's a couple of questions here about surgery, if you don't mind taking them. The first one was from Helen Branthwaite, which says, do you have any insights into why females are more likely to have surgery? So is the first question.
So it's a good question. Osteoarthritis is actually more common in women than men. It is probably as simple as that. For hip surgery, some of the reasons that women have, or that people have hip surgery in younger age groups, are also, it's the dysplasia, the dislocated hip, dysplastic hip spectrum, which again is significantly more common in females than males. So those are the main reasons, I think.
Excellent. Thank you so much, John. The next question is, with current delays for surgery, how do our MSK services work with orthopedic colleagues with regards to the role of investigations, mindful that spinal surgeons locally often look to repeat MRIs or to do so within 6 months once the date of surgery has been confirmed? Keen for your views on that, John.
Sure. So I think we'd all say that the NHS does not tend, I think we all do this, doesn't tend to communicate well with itself. And that's the thing that is incredibly frustrating for patients and for all of us. And I think we've got to try and improve that. I think with patient records, and certainly now imaging is much easier to transfer. If you had an MRI scan in hospital X, I could get it transferred to me in hospital Y the same day via the image exchange portal. So that can certainly happen. It's about communication. It's about us being aware where the investigations have been done, and just really keeping a record so that we don't waste scarce resource. Because I mean, the point you make is right. At the moment, imaging is incredibly valuable resource, because in order to keep X-rays, MRI scans, CT scans, COVID safe, the volume drops dramatically. So we mustn't waste them, and we must only target and do imaging that's important and necessary at each time.
Excellent. Thank you, John. And a fantastic question, really relevant in these times where there may be gaps in care. What does that mean on that whole end-to-end pathway? So thank you, John, for your answer. Sally Pembry, thank you very much for clarifying the heart of your question. And actually, I'm going to ask it of all three of the panelists, because I think we'll each will have a different lens on this. So she says, my question was more about how do we make the physical session of an appointment feel less rushed for one person, etc. So I'll go to each of you. Rebecca, can I start with you, and then Alex, and then John? How can we make the physical session of an appointment feel less rushed? Does anyone have any tips or advice?
I suppose there's sort of like, a kind of superficial answer I could give in a sense that is sort of would draw your attention again to sort of like the top tips, which I was just rereading actually, which are just things about sort of along the lines of slowing down the pace of the consultation and trying to demonstrate active listening, proactively checking what the patient needs, things like that, which I think would apply whether you are meeting someone face-to-face or online. But I suppose there is a big, much deeper, more structural question around how you make appointments less rushed, which is that you have to create the sufficient resources and time to enable clinicians to be able to have the kinds of conversations that people want and need to have. And that's come up recently for us in work that we're actually doing around the sort of the very long and porous line between physical ill health and mental ill health. And about how, one thing that's coming out of that work is that we think that it would be, best practice for any appointment with anyone who is experiencing physical ill health, and particularly those living with long-term conditions and pain, to be asked, are you okay? How are you at the beginning of the session, rather than going straight into what you've come for here today. But it's one of these things where without creating the time and also skilling people up in how to safely hold those conversations, it's incredibly difficult to actually do that. So I think, yes, follow the top tips and then think more about the sort of structural changes we need to give the clinicians the time they need to support patients.
Great, Rebecca. And I'll just do a cheeky plug for the Personalised Care Institute off the back of that, which is not directly related to National Voices, but it outlines some of the knowledge, skills, and confidence to increase clinicians' confidence in being able to implement that in practice, specifically regarding shared decision making. And that the link is in the chat further up as well. So just to build on what Rebecca said from my day job's point of view. Alex, John, do you have any comments to add to that in relation to creating that physical space within the physical appointment and tips for clinicians who might find that challenging at the minute?
Yeah, so from our perspective, actually, this is one of the sort of positives that's come out of the COVID. The need to socially distance has led us to completely restructure the way we've delivered our outpatient services. So a typical clinic template now in where I work will not have more than 8 patients or 7 patients in a session, because we're staggering patient arrival through the outpatient department. You know, an outpatient clinic at St. George's will have 6 or 7 different clinics going on at any one time. And typically in the old days of old, we might have had 40 or 50 patients in the waiting room at any one time. And that's now been reduced to never having more than 6 or 8, maybe 10 people in the waiting room. So appointments are all given 20-minute slots with actually a 10-minute break. So people are getting 20, 25 minutes if they need it. And I think that's a really positive. And actually the telephone consults that we do are the ones that both the patient often and the surgeon feels would benefit from just a short catch-up consult. You know, not every consult needs to be 20, 30 minutes. You know, you need a good big one in an initial meeting. You might need one as you're coming up to doing an intervention. You may want one if there's a problem, but for routine follow-up checks where it's really, I've seen your x-ray and you know, we're just checking everything's coming together, we move those to telephone, and that gives us a lot more capacity on the face-to-face. First impressions of that were really frustrating as a surgeon. You're sort of sitting there going, this is awful. I used to see 30 people in a morning. Now I'm only seeing 10. But actually the quality of the consultation has got a lot better.
Thank you, Alex. Really helpful context for us to be considering this. And actually, I really enjoy the multi-professional perspective to add to this, because the question was coming from a physiotherapy appointment perspective, but I think for all of us, it's just how we consult and what we use to sort of shape that to not create that rushed space. Thank you so much for your insight. And John, do you have any thoughts to build upon this discussion? Or we do have some other questions in the chat as well. I welcome your views.
No, I mean, I'd agree with Alex that I think what we have done is we're seeing less patients face to face, so we are seeing them better and in a less stressed, less rushed environment. I think the most important thing is when you see a patient is to look the patient in the eye and to listen. And if you give those two things, then you're already a long way down the way to getting the diagnosis right, to getting the trust of the patient, and to making the right decision. And I think because they're a scarce resource, we all of us have to make face-to-face appointments really count. So that if we see a patient, we've got to work out what the plan is, what we're going to do now, and if we're not going to operate or do an intervention now, when are we likely to do it? And I always ask the patient, I mean, I think you're absolutely right, you have to share the decision making. I'm a surgeon. Is your pain bad enough to have an operation? Because patients, I mean, it ought to probably be asked before they get to us, but it does need to, everyone has a different view on that, a different view on risk and how they perceive it. So I think those would be my tips. But I think
absolutely, I totally agree. And as a clinician by background, and you wouldn't expect anything else from me other than ambassadorizing personalized care. To me, it's that bringing together of the power between the benefits of the knowledge of the clinician and the knowledge of the person about themselves, and that mutually respectful relationship and carving out that space together. Nothing's better than that. Excellent. Well, we have a number of other questions in the chat. We have 3 minutes left before our well-deserved stand up and move around break. The one with the highest votes so far is, with a limited number of orthopedic surgeons, how will the surgical waiting list for total hip replacements reduce significantly? And are there plans to increase the number of surgical trainees? I'm looking more at Alex and John here with this one.
Sure. I'll have a go at this one. I mean, we have got a massive backlog, and it was a big backlog before the pandemic came in. So We've got to look at ways to deliver surgery for patients safe. I think from the British Orthopaedic Association point of view, what we actually want to do is to plan long term, that we need to have cold elective sites in every region throughout the country where you can deliver planned care safely and effectively. You can minimize the risk of infection. There was a time, well, it still applies, but we worried about bacteria with joint replacement. So by ring fencing beds, having units that that just specialize in orthopedic operations, cold elective operations, you don't cancel patients, you get the safest environment for patients. And that's got to be the way, because those are also the units easiest to make COVID light and pandemic proof would be the first thing. We have got to get a big backlog over. It may involve using the private sector, because those do tend to be cold sites. We've done it before in the 90s, when there was another big imperative to reduce waiting lists. It can be done. It's expensive healthcare, and we'd probably much prefer the money to be invested in NHS facilities and build a solution for the long term. But there's a will to do it. We've just got to allow it to happen. And the other thing is, in a hospital, it is easier to prioritize almost every other specialty above musculoskeletal conditions. And it is still a thing that, well, it's just arthritis, nobody dies of arthritis. Let's prioritize cancer, heart disease, mental health, diabetes care, whatever it is. And it's just not true. It is important, and we've got to keep people moving. We know we've got to keep people, mental health, we can contribute to every single aspect of a person's living. We can improve by keeping them mobile. But that message.
Thank you so much, John. Alex, do you want to come in on that at all?
Yeah, it was just to address the second part of that question, which was about training and the need to produce more elective arthroplasty surgeons or orthopedic surgeons. I think that would be lovely. I can give some information with my training program director hat on, so I have a little bit of insight into orthopedic training in general. I think the reality is actually COVID has caused a bit of a bottleneck with orthopedic progression, and that's going to take a while to clear. And I suspect as well, as much as we champion orthopedics, the bigger picture is that the government will want to see more GPs created first and foremost, more primary care physicians, before they ask for more hospital doctors. So I think what we've got to get better at is being more efficient in the way we deliver the care with the resources we have. And that's going to be our biggest challenge. And that's going to come down to using our lists more effectively, moving things to 3-session days, weekend operating. As John says, elective site, we have the South London Orthopaedic Elective Orthopaedic Centre that does about 5,000 joints a year that's protected. And I think that's the model going forward. More of anything is very unlikely to happen anywhere in the NHS anytime soon.
Alex, thank you very much, and John as well. And you know what, this goes as a lovely segue into our next session, which is around workforce, a provocation session from Natalie Beswetherick. So you've ended perfectly, Alex, on some thoughts for us to take as we stand up, move around, have a break, and then come back into this session at 12:05. A massive thank you to our panelists this afternoon, describing things, doing things differently, learning through COVID through a number of different projects. Fantastic panel, thank you very much. Now everyone, go for a stand up, move around, break, modernizing our thinking around use of workforce. But it really created a lovely segue and think piece for us whilst we were having our 5-minute stand up, move around break. Over to Natalie Beswetherick, who's going to offer us a provocation around workforce. Over to you, Natalie.
Yeah, thank you very much. Just making sure I can get it from the beginning. So thank you very much, Aimee, that's great. So just before the next lunch stop, I'm going to be talking a bit about workforce. And so in this very short presentation, I'm going to try and make it as quick as possible. I want to discuss about the nature of the workforce we have. And I want to challenge the practitioners here who are providing rehabilitation for people with MSK disorders.
about do they need to change in terms of the type of practitioner they are to ensure that the patient populations receive the rehabilitation they need and how they want to receive this. We've known about the demographic changes for decades, yet there's very little indication really that we've changed the way we provide services, and certainly who is providing those services. The yellow lines on this ONS graph here show the impact actually of the baby boomers. Some of you may be on this call. They were born in the sort of 50s, 60s, and at the end of this age range of 2043 will be about 80 years old. So you can see that the age, we are continuing to get older. And coupled with this, the number of people of pensionable age is the biggest group that's going to increase in the future. So the number of people will continue to grow in that pensionable age group. But what do we know about the population and the aging population? Well, what we already know is that people are living longer in poorer health than they were previously. And this is continuing to rise. I mean, this data from 2018 is pre-COVID. Just think of the impact of COVID on many undiagnosed cancers, long-term conditions, including, as we've heard already about, inflammatory arthritis. Also the lengthy waits, the impact of the lengthy waits for surgery, as we've already heard from John, and becoming less active, which we are all familiar with, not just with lockdown, but for those who've been shielding. I think this will mean, as we look forward in the next few years, we will see that there'll be even more years lived with poorer health. And as Andy already actually alluded to at first thing in this morning, we are increasingly less active. And for many of you who either have a musculoskeletal condition or you are involved in treating and managing long-term conditions such as MSK conditions, the lack of activity actually does make this worse. And I think, isn't it shocking to see that it's predicted that we're going to be even 35% less active by 2030, but around 30% of that contribution of physical activity leads to later life functional limitation and falls. So it's not great, is it? And I think it's well worth remembering, and again, Andy alluded to this, the importance of us being active and having a healthy MSK. Because if we don't keep strong and keep our balance, then we are going to have those more years with not aging well. So again, it goes straight back to Andy's first presentation of the day. And you can see here on the graph that the green line denotes successful aging with much better health by doing regular strength and balance activity. And the blue line below it shows the decline in strength and balance if it's not part of an activity throughout the lifespan. And then COVID came along, and it's been a moment in time, as we've all mentioned today, that we've had to be really innovative. And we heard from speakers looking at the challenge and the changes that people have suggested we need to take forward. And we have provided as much access to services as we can by doing things differently, and perhaps some will argue more efficient and effective and safer. And as already Rebecca from National Voices has covered earlier on, massive positives and some negatives of the digital transformation that we have seen. I mean, prior to the pandemic, it's true that the health and care system had a very poor track record in adopting any digital technologies at scale. And then when COVID hit, many services moved to virtual delivery overnight. It was truly amazing. And there are more technologies and digital technologies we can adopt and deploy to achieve better outcomes and more efficient care and improved patient experience for many. But on the downside of COVID, we are less active. And many of you will be aware that sitting or lying is a real independent risk factor for health. And it is also still shocking. I mean, it's more than 7 hours, I suspect, for most of us at the moment, since lockdown and since we've been not able to do as much as we used to by working at home. It's probably more than 7 hours a day. And we know that that increases anyway with age or if you've got a limiting illness. But 7 hours a day is really unhealthy. And I'm talking about, going to talk about a bit about long COVID because it does actually have an impact, I think, on what it's showing about what we might need in terms of rehabilitation for the populations, including the MSK populations. What we've seen so far is that it does affect multiple systems. The symptoms include fatigue, breathlessness, pain. We know it's non-linear. The symptoms fluctuate. And I suppose at the moment, because it's still very, very early days, the trajectory of it is unknown. The CSP recently did an audit called PACE, which is Physiotherapy After COVID Evaluation. This was a 4-week audit undertaken during the summer. What was really interesting about the findings from all the data we actually got in was the large number of patients with multi-system issues impacting on rehabilitation and rehabilitation needs. And they did include existing comorbidities, cognitive impairment, extensive deconditioning, but also mental health issues, as well as the usual social environmental issues. Knowing what we know from all that, I think it's important that we reflect back on the type of models of service delivery we may need for the future. And I saw some questions earlier on about the focus being seen as very much in secondary care still, rather than in primary care. But where we need to see patients, it needs to be community-based, and those workforces need to be multidisciplinary. These models should not be dictated by a single condition or specialty, because the populations we see have got more than one condition. And the majority of people, as they age, will have 3+ long-term conditions. So we do need a multi-condition approach that's needs-led, and that there are choice and options for people in terms of how that rehabilitation is provided. That may well include remote for some. It could be face-to-face. It could be a one-to-one, or it could be in a group. But the choice is critical. If you're going to deliver patient-centered care, you've got to give people the choice. Other speakers have already talked about the importance of integration across pathways and its health and care sectors. And because of the enormity, and we've heard already today about the enormity of how many people are not having the interventions, rehabilitation that they need, we have also got to take a strong preventative and also a self-management approach. I put this in because I think the work that David Oliver did, and this was obviously really focused on the aging population, but it actually does include all the elements we should be thinking about in terms of rehabilitation for all. People have quite a lot of the multiple conditions, some of which are more easier to see and understand than others. But we need to be ensuring that people can age well and stay well, as Andy referred to this morning. So what type of workforce do we really now need for the future? I think for decades, the workforce to a large extent has comprised specialists and generalists. But is that right now? The population has changed. It's aged, it's got far more long conditions. It's not just about one thing. It is about many, many different long-term conditions that we need to respond to. And I do like this model where you see the bringing in of what is called a versatilist. And note the difference between the versatilist and the specialist. They've got very deep skills, but a very wide experience. So I believe we need more versatilists with that breadth and depth in knowledge, experience and scope to manage these population needs and the rehabilitation they're going to need. So to summarize, COVID has given us an opportunity to really reflect, as we've heard from others, about what we need to provide for the future. It has enabled us to transform services in a very short period of time. We can utilize our transferable skills as practitioners who are providing rehabilitation. But I do think we need to think about our breadth and depth. I think we need far more people with breadth and depth to meet what is going to be increasingly a complex patient needs. And we need to be able to respond to those needs at an individual level. And I think for all those practitioners, I want you to think about what you might need to learn more about in order that you can provide that breadth and depth in the jobs you have. All the people who are providing rehab need to remain agile and to continually adapt as the new evidence emerges. We've only seen the tip of the iceberg with long COVID, but that gives us a strong indication of how much we need to get more breadth and depth in providing rehabilitation. Thank you very much.
Thank you very much, Natalie, for a wonderful outline. There's been some really useful discussion in the chat and a few questions that have emerged. What I might do is take one question here and then offer the delegates attending today to, in this session over lunch, there's both the option for networking where the speakers will be present, as well as the exhibition area. So I'll do one question if that's all right, and then we'll sum up from there to let people get food, get moving again as well. So there's one question from Mark Sanders for you, Natalie, around, oh, no, another one's been voted, from Phil Bright, which is how can big employers be engaged to invest in MSK Health if their workforce, when productivity drives the economy, which can mean fixing employees to desks and screens?
Can you say that again? There's quite a bit in there.
Sure, yeah. So what can employers do to be engaged to invest the MSK Health of their workforce when productivity drives the economy, which can mean people being fixed to their desks? What are your thoughts on that?
I think employers have got a fantastic opportunity to do the piece about working well. So it's not all about being tied to your desk, though, because I think the one thing that COVID has brought to many of us, I'm now working from home and have been doing since March, but it's about driving into the changes where we're working at home, into putting in those breaks, to actually keeping people active, to doing things differently, suggesting that people, say, do take your full lunch hour and going exercise during the daylight hours, for example. And it's about making those changes, and for the employers to be driving that, you will get more productivity from your workforce, because if you've got a healthy workforce, you've got a more productive workforce.
Excellent, thank you, Natalie. And then a strong theme that's coming out in a few questions, which is around how do we support our workforce to develop more versatilists?
I think this is at different levels. I think what I can see is that we need to really consider about what individual practitioners need to think about. What do they need to know more about and develop that themselves? So that's part of their CPD and professionalism. I think in terms of our training and education, we need to look right from the beginning of practice, whichever discipline you're in, to look at the much wider knowledge and breadth and depth. So your clinical placements are different. It's not just about traditionally just working in one area. It's making sure that you've got the breadth of that clinical experience. And I would argue that we need far more of that being done in the community. Often remember, the majority of our population never hit a hospital in their life. They do actually seek primary care services. So I think we need far more in primary care to be done, so people are experienced and see the complexity of people living with long-term conditions in their own homes and in their communities. So it needs to be done at all levels to increase that breadth and depth and have a much more resilient and versatile workforce.
Excellent. Thank you so much, Natalie. And thank you to all of our panelists for this midday session, including the beneficial changes work, restarting orthopedic services, and the digital work with National Voices, as well as your healthy provocation, Natalie, about what do we need to do within the workforce to rise to this challenge that we face now. Thank you to all of our panelists.